in terms of ancillary studies, which are becoming, I guess before there really weren't very many ancillary studies that you could do. Now there are increasing amounts of different studies you could do with material that you don't use to make slides. So basically, prior to ProCore, what we would use for ancillary studies is that we would do, or the GI docs would do a fine needle aspiration of the pancreas, and instead of making slides, they would just squirt all the material into solution, and we could take that back to the lab with us. So we wouldn't get any slides from those passes, but we would just get a vial of solution with cells and chunks of cells suspended in it. Alternatively, what they often do is that after they squirt the material onto the slide to make the smears, there's still going to be like a few crumbs or little cells left in the syringe, left in the needle. So you'll suck some solution into the syringe and then squirt it back out. So you'll sort of do what we call a needle rinse. You'll rinse out the syringe and needle, and you'll clear out any little bits of tumor or any individual cells into that solution, and you can do ancillary studies with that as well. So yeah, either dedicated passes that you squirt right into the solution, or else you rinse the needle. That's what you can use for these ancillary studies. And generally the solution that we use is either RPMI, which is just this cell culture medium that keeps the cells sort of alive till we get back to the lab, or else you can use Cytolite, which is more of an alcohol-based solution. And so what are the different ancillary studies we could do? Sometimes we just make more cytology slides out of them, sort of make like, we'll centrifuge it down and we'll just stain it like we would the smears. So it's just more cytology to look at, but we don't often do that. Usually the two ancillary things that we're most interested in, first is flow cytometry. So flow cytometry is a technique. It's this machine that you run the cells through. And if you're dealing with something where you're worried about lymphoma, this machine can tell you if you have small lymphocytes, if they're lymphoma or benign, because under the microscope they'll look the same. You basically need this machine to tell you, are the proteins they're expressing more like lymphoma or more like reactive. So if we're worried about lymphoma, we'll say, get a bunch so we can send it for flow cytometry. And that's basically what that is, to distinguish, A, is it lymphoma or benign if you're dealing with lymphocytes, like you're in a lymph node, or B, once you're sure it's lymphoma, what kind of lymphoma is it? That's what flow cytometry can do for you. But that's, again, sort of the minority of cases. Usually what we're more interested in regards to ancillary studies is making a cell block. And the cell block allows us to do something called immunohistochemistry, which I'll get to in a minute. So, I don't know, have you heard them talk about making cell blocks a lot when you're up there? Yeah, so that's really important for us in a lot of different scenarios, which I'll get to a little bit later. But basically what you do when you make a cell block is you take the RPMI, that's solution, and you'll put, we'll actually introduce blood proteins into that solution. And what these proteins will do is they'll just make a clot. They'll just make a blood clot. And what that blood clot does is it'll basically end up sucking up all of the individual cells and groups of cells from the biopsy that are floating around in the solution. So instead of having cells sort of just floating around in solution, you'll get this clot that's a combination of, again, these blood proteins and also the individual tumor cells. So once you have this clot, you can basically treat this like it's a piece of solid tissue. So like if you're going to breast biopsy or you were to get like a colon biopsy, they don't take individual cells like in an FNA. They get a piece of tissue. So once we make a cell block, we convert this solution via a clot. You convert it into a solid piece of tissue. Once you have a solid piece of tissue, you can fix it in formaldehyde or formalin, and you can embed it in wax, and you can then cut it into thin sections and either look at it under the microscope or do ancillary studies with it. So again, you're basically converting the cells in suspension into a piece of tissue that you can now do ancillary studies with, similar to if you were to get, again, like a breast biopsy, prostate biopsy, whatever, where it's a solid hunk of tissue. So the main advantage is that this tissue is suitable for immunohistochemistry and other ancillary studies, but mostly immunohistochemistry, which I'll get to, is what we're interested in. Since you're fixing tissue in formalin, the analogy I like to make is sort of that you're pickling the cells. So the morphology isn't as good, but you now have the advantage that you can do these ancillary studies. So, again, if Diffquick is fried egg, Pap is a boiled egg, this is like a pickled egg. Or like a raisin relative to a grape or something. So you still have the cells there, you can still tell what they are, but they've definitely lost the morphology that they had before. And it's harder to make fine distinctions. So I'll just show an example here. So those two slides at the bottom, those are the smears, again, where we smear stuff out on the slide. and we have that thin layer of mucus, blood, and cells, and we do our PAP and diff quick on it. On top there, you have a cell block slide. So again, what was done was that we put in a little bit of plasma protein, made a clot. The clot was embedded in paraffin wax, like with tissue biopsies, and it was fixed in formalin, and then cut into thin sections, and one of the thin sections was put on this slide and stained. So it's very pink to red, because really 95% of it is going to be blood and those plasma proteins, and you'll just have a few little specks of cells in that clot that you can work with. So here's a picture of a cell block under a microscope, and again, you've got a mixture of sort of blood, and you've got these plasma proteins, and then you've got sort of, this is actually a pretty good example of a cell block. You've got individual cells and maybe little clusters of cells as well. So you can see that the morphology isn't nearly as sharp as we had on the PAP or even in the diff quick. But again, we now have the advantage that we can do ancillary studies like immunohistochemistry. So what is immunohistochemistry? Like, I'm sure you guys have heard people talking about that, but what exactly does it mean? So in a nutshell, like, what does it do for us? So the problem for us is that a lot of different tumors look the same under the microscope, especially if you're dealing with a very small biopsy, like in an FNA. So the pieces of tissue you'll get in an FNA and a cell block, they're tiny. I mean, they're smaller than grains of sand or salt granules from a salt shaker. These are like minute pieces of tissue. So you're dealing with very minuscule amounts of tissue, and then a lot of tumors can look the same. So you have this problem of wanting to get one level beyond morphology to tell what they are, because morphology can only get you so far when you're dealing with such small amounts of tissue. So what immunohistochemistry lets us do is it's a way for us to highlight the proteins that a tumor is making. And I'll sort of give you a more concrete example in a minute. And so based on knowledge of what the cells look like and what proteins that we can demonstrate that they're making, we can then make a diagnosis. So the important thing here is that you can't do this on FNA smears. You need to have something that's been fixed in formalin and embedded in paraffin, i.e. a cell block, or as I'll get to later, a ProCore biopsy. So we can't do this on smears. We need something that's been, a piece of tissue that's been fixed in formalin and embedded in paraffin. So either cell block or ProCore that I'll get to later. So just as an example for you guys, so this was a case we had maybe a couple of weeks ago. You can see that it's not like, it doesn't have different colors. They don't really use the normal stains on these immunohistochemistry slides where we have a pink stain and a purple stain or a blue stain or something along those lines. So just to give you the background of this case, this is a patient that had kidney cancer, and then they had a pancreas mass. And Roger Shree biopsied this pancreas mass, and we looked at it and we're like, okay, it looks kind of funny. It's either going to be pancreas cancer or it's going to be metastatic kidney cancer. And obviously this makes a huge difference in regards to what you're going to do for the patient. So what we were able to do, since we had a cell block in this instance, is we were able to say, okay, we can look to see if this is making kidney proteins or pancreas proteins. So we'll cut a bunch of slides off of that cell block, and we'll do a stain for kidney proteins on some of them and pancreas proteins on the other ones. And so in this case, this tumor was positive for kidney proteins. You can see it's turning it brown there. So it's a little bit more complicated than that, but in essence, that's what it is. IHC is a method whereby you could see what sort of proteins a tumor is making, and based on what proteins it's making and what it looks like, you can make a more firm, definitive diagnosis of what it is with a lot more confidence than just looking at it and doing morphology alone. So we rely on this very heavily, and so this is why we place a huge premium on getting, either cell blocks or ProCore biopsies in a lot of cases. Does that make sense? Okay. All right. So we just went over the FNA sort of cell block paradigm. So this is, again, what we sort of had in the past. FNA gave us good morphology, a combination of that immediate stain, the diff quick, and the more accurate stain, the PAP. And also, we would, using needle rinses or dedicated FNA passes, we were able to make cell blocks that we could then use for IHC. So just to put it more sort of visually, you'd do FNA passes, make your smears, or you'd put it in RPMI and take it for ancillary studies, which usually meant making a cell block and doing IHC. So that's sort of the paradigm that we were in, just to put it more visually. All right, so and that generally worked pretty well, but where does it sort of go off the rails and fall apart, and where does it come about that we're going to need sort of more help with cases? So the two things that sort of would throw a monkey wrench into this paradigm is that, if the endoscopists are dealing with a very hard, gritty lesion that's got a lot of fibrosis and they just can't get a needle into it, or the needle sort of just bounces off of it, then you obviously can't get an FNA. And if they can't get an FNA, then we can't really do anything because they're not giving us anything to work with. Situations where that tends to arise is if you have like chronic pancreatitis, so a lot of old inflammation of the pancreas. It tends to scar down, get very hard, so they can't get a needle into it. Also, certain tumors, like these, what they call GI stromal tumors, tend to be very hard, and they can't get a needle into those either. So those are harder to biopsy. And then again, we don't get material, and we can't really do anything. So also, again, the amount of tissue that we end up with in a cell block, you saw it was pretty big the way it looked on a slide, but again, it's like 99% blood and clot. So even if you get good aspirates, you don't always get a good cell block. And if you don't get a good cell block and you don't have material to do immunohistochemistry, then a lot of times that's going to impair your ability to make a diagnosis as well. So this is sort of the two failures of FNA and cell block when it doesn't work.